We'll talk about cirrhosis. This is going to be in chapter 59, pages 1461 to 1468. So as far as your risk factors, you got to think about your chronic hepatitis A, B, or C infections. That's going to be your number one risk factor, followed by chronic alcohol use. You can have biliary disease, which pretty much involves obstruction or infection around the common bile ducts within the liver. You also have non-alcoholic steatohepatitis or NASH. That's going to be due to fat accumulation around the liver. You'll see this a lot in your obese patients. Then you also have autoimmune liver conditions or genetic disorders. I want to say the book mentioned like Wilson's disease or hemochromatosis. I want to say that's too much iron in the blood. But needless to say, remember, as far as the blood flow in the body, that's like your traffic jam. So remember, your right-sided heart failure patients have a backup of traffic in the systemic blood flow. So if you constantly have backup to, as far as the tissues, back to the liver, this can also lead into cirrhosis as well. So this is going to be figure 59.2 as well as figure 59.3. So the first one is going to be your cirrhosis. Remember, the liver tissue is just like, if y'all remember SpongeBob, I'm sure y'all do. There was an episode where somebody kept pulling SpongeBob's arm out and it kept growing back, growing back, growing back. I forget what the name of the bully was, but either way it goes, the liver has the same concept. So the liver can regenerate itself, right? So if you constantly have more injury to that liver tissue, after a while it's replaced with fibrous tissue as well as nodules. And this is what you'll see in cirrhosis. So your liver failure patients also experience what they call ascites, and this is pretty much like an accumulation of rich fluid, pretty much protein. With that acidic fluid, or ascitic fluid, I'm sorry. If you get more than half a liter, which is 500 milliliters, within that abdominal area, the patient starts experiencing issues with being able to breathe, abdominal girth, pain, as well as bloating. So we're going to roll on a little bit of a commercial break. When you look at the pathophysiology of cirrhosis itself, your core of it is pretty much chronic liver disease. You have destruction of hepatocytes. We talked about in the previous slide about the regeneration of that tissue is going to form nodules and fibrous tissue. This is going to cause abnormal capillary networks, and it's also going to disrupt your normal blood flow. Think about all of your normal functions within the kidneys anyway, right? You also have a decrease in your portal vein flow. The hepatic artery, that's going to be the artery that feeds into the liver itself. It's going to become the primary blood supply for that patient. What you end up getting is liver cell necrosis, structural distortion, as well as impaired liver function itself. Okay. Our consequences for this, we have things like portal hypertension, scarring of those portal vein branches. Remember, we talked about the blood traffic flow. You got to back up, and it's going to put more pressure on the GI venous system. The blood bypasses so this is like capital circle. It's going to bypass your liver cells, and what happens is you have lower levels of detoxification. Remember, the liver is a filter for the body as well. Some other things that you'll see due to that backup of blood flow, you'll have esophageal and gastric varices. We'll talk about this later on in the chapter or in the slide. This puts the patient at risk for increased GI bleeding. They're also at risk for hemorrhoids. They're also at risk for abdominal vein distension. If you have injury to the liver, you're going to have insufficient function. You also have lymphatic congestion. So some of your secondary changes due to that are going to be the ascites. I talked about that in the previous slide. These it's pretty much going to lead to a poor quality of life, greater infection risk, poor prognosis for the patient. They also can have pleural effusions because of that diaphragmatic fluid shift. Remember, your kidney does function in regards to synthesizing clotting factors. So if the liver is affected, you have a decrease in the synthesis of those. These patients become bleeding risk. They bleed very easily. They have thrombocytopenia. Their PTT is prolonged. Remember, that's the clotting. That's the clotting, the lab work that we get to look at the clotting factors within the blood as far as the lab work is concerned. Let's see. You also can have, per se, excessive bleeding from the GI system, lungs, any type of wounds, IV sites. My mother-in-law, before she passed, she was an alcoholic, and I was not at work that night, but they were telling me they had to go and get an IV on her, and they were talking about how bad she bled. So anytime you have, per se, an alcoholic or somebody with cirrhosis, they're going to have a lot of bleeding issues, ecchymosis. You just want to be careful with them, especially when it comes to bleeding. Another issue you can have would be the hepatic encephalopathy. Remember, with the liver, it helps synthesize the breakdown of protein. Your byproduct is going to be ammonia. If you have an issue with the organ that synthesizes that process, the ammonia level builds up in the blood. This causes CNS disturbances. The patient's confused. They can go in a coma. This also can be triggered by dehydration, infection, and some type of medications, even surgery. Depending on the severity of it, it is staged, if you will. It can cause seizures. This is going to be table 59.5. It's coming straight out of your book, but it pretty much lists the different stages and the signs and symptoms that you'll see for a patient with hepatic encephalopathy. Keep in mind, with a lot of your liver failure patients, their prognosis as well as the management of them, once cirrhosis starts, it's irreversible. And our focus, we want to prevent the progression of it as well as stop the complications. The worse that the condition gets, depending on what caused the cirrhosis in the first place, your end goal will probably end up being liver transplantation. And we'll talk about that later on in the presentation as well. So as far as our signs and symptoms, the things that you would expect to see, they're all listed on the slide. You got your shortness of breath. This is going to be due to that ascites in the abdomen, the fluid buildup or whatever. You got the jaundice. Remember, the liver synthesizes bile. It's not being able to do that anymore, so you have an increase of bile circulating in the bloodstream, and it gives the patient a orangey, yellow, highlighter type color depending on their skin complexion or their ethnicity. I think that's how it's pronounced. Forgive me if I mispronounced it. Let's see, what else do we have going on? We have hypertension. We can have spleen enlargement. Remember the traffic flow, the traffic of the blood flow. Let's see. And I just want to reiterate that ammonia levels in the blood are important. This is going to be associated with that hepatic encephalopathy. The medication that they give for this is called lactulose, and it helps to excrete that ammonia through the intestines. A lot of times the patient takes it, their expectation is to have like multiple soft stools. What happens is when you work with these patients, unfortunately, a lot of the times the nurses get tired of them pooping, so they'll hold the medication, or either patient gets tired of pooping and he was like, I don't want to take that right now. Keep in mind, if you don't give them the lactulose, all it's going to do is cause the ammonia to build back up. So in your shift, if your patient continues to refuse the lactulose because they're tired of having bowel movements, as you see a mental status change in your shift, keep in mind, okay, we need to start back giving them the lactulose. There's a possibility that their ammonia level is building back up. These patients also suffer from hyponatremia. Remember your, as far as your electrolytes, that salt is going to follow water. So you got all that fluid in the abdominal system, so the sodium's going out there away from the bloodstream. Okay. This is going to be your table as far as your labs that we're looking at. This did come off of AI. However, this is straight from your book, the chart that's in your book. So when we look at cirrhosis, the main ones we do look at are, excuse me, ALT, AST. They'll be elevated. That's indicative of the liver failure. You got the alkaline phosphatase, the total, as well as the one with the liver, bilirubin, albumin. Remember, with ascites, you got protein in the abdominal cavity and not circulating within the bloodstream, so it's going to be low. I talked about ammonia already, PT, APTT, as well as the platelets. Also, keep in mind, I think I read somewhere in your ATI, they were talking about alpha fetoprotein. So that one is also affected as well. But the book doesn't really talk about the alpha fetoprotein from what I could see, but I do know that it's in your ATI book. This is going to be your clinical presentation of your patient with cirrhosis. This also is figure 59.4 coming straight out of your book. Keep in mind this patient has the hepatic encephalopathy. I want to say the book talked a lot about the asterixis. That's going to be where you have a situation where they're extending their arms and they have a lot of uncontrollable flapping within the hands and the wrists. Jaundice, of course, hepatorenal syndrome. We talk about that later on. Spontaneous bacterial peritonitis. We talk about that later on. As you see down there, you got the coagulopathy. That's going to be the bruising, the excessive bleeding. Remember the traffic flow of the blood. I keep going back to that. So this is what's going to cause those spider veins, or the spider angie. I think they call it like spider veins, but you'll see like random veins on the patient's on the belly, taut, distended. So when you got that backup caused with the blood flow, you're gonna have a backup within all of those areas. We'll talk about varices more. So remember, with your varices, you have them in the esophagus. And I want to say in the abdomen. So keep in mind also that a hemorrhoid is a type of varice as well. It's just in the anus. So the best way that I describe the varices in the throat is like a hemorrhoid that's in your throat. These patients do have issues where these rupture a lot. That's pretty much what my mother-in-law died from. She had a varice in her throat that burst, and she did not know it, and she pretty much bled to death in her living room. So just keep in mind, with the issues with blood flow through the kidney due to cirrhosis, you're going to have a backup of blood, enlarging of organs, creation of new veins all over the body. So when you look at your diagnostic overview, of course, we want to assess liver damage severity. It's going to help us guide any type of clinical interventions. And of course, we do all this by combining that physical exam with that diagnostic testing. So with that, your key tools are going to be your ultrasound or CAT scan, your non-invasive imaging for your liver abnormalities, EGD or endoscopy. That's going to help visualize that esophagus and the duodenum. We're looking for varices and GI bleeding there. You have portal angiography. This is going to help you visualize that portal venous system. One of the most definitive ones would be the liver biopsy, and we'll talk about that later on in the presentation as well. You also have ERCP. I can't remember what it means right off, but I know it's going to be in the other presentation, so we'll come back to it. But it's a very long word, so we just say ERCP. With this one, it's going to combine that endoscopy and fluoroscopy. And it diagnoses and treats any type of biliary obstructions. So remember, with your liver issues, you have the gallbladder that's right there close to the liver. You have the pancreas that's right there close to the liver. So keep in mind, if you have any issues with either of those organs, it's going to affect the liver as well. I want to say the book mentioned transhepatic cholangiography. This is going to be that imaging of those bile ducts via contrast and a scan. It helps us look at where the obstructions are. Also allows stent and drain placement. Your liver biopsy, of course, this is going to be the one that they'll definitely confirm it with. It's done either percutaneous, transvenous, or surgical. Keep in mind, with these particular patients, after the procedure, they're on bed rest. We have a sandbag or some type of pressure dressing on that site. I want to say you want to lay them like on their side to help that abdomen put pressure on that area. We also monitor this patient for any type of bleeding or hypertension. This is going to be your liver biopsy photo. It's invasive, of course. We have to have a consent in order to do it. And we're going to collect a sample of that liver tissue to determine how severe your cirrhosis is. Your safety alert. Remember, these patients are at risk for bleeding. So if you have any type of change in the level of consciousness, decrease in blood pressure, this could indicate like hemorrhaging. So you want to make sure that you notify the provider of what's going on with the patient immediately. All right, a nurse is caring for a client who is post-procedure for a liver biopsy. Which of the following actions should the nurse take? You want to make sure that you have that client lie on the right side for 2 hours after the test. And pretty much, again, the rationale for that is allowing that patient to have extra pressure placed on that biopsy site to help with minimizing bleeding, excessive bleeding, and also helping the blood, the clot in that area. So we have yet another commercial break. When we look at our ascites management for these patients, remember salt follows water, so we want to restrict the sodium, less than 2 grams a day. You want to give them spironolactone as well as furosemide combos. Keep in mind monitoring your potassium levels. I forget right off my head what electrolyte the spironolactone affects, but keep in mind those are diuretics that affect electrolytes. I think the spironolactone affects the potassium as well, so you just want to keep an eye on that. Your paracentesis, this is going to be removal of that fluid from the abdomen to help with relief of the symptoms. Keep in mind, whenever you have excessive ascites or excessive fluid within the abdominal cavity of the body, right? So the physician goes in there, pulls off a whole bunch of fluid, which gives the patient relief, but at the same time, it has not given the body, the organs, the veins, all of those things. Forgive me. It hasn't given them time to adjust. So what can happen? This patient can have hypotension after the procedure. So you don't want to pull a lot of fluid. You want to pull enough to give the patient relief, but you don't want to pull so much that you cause hypotensive issues. Okay. Portal hypertension is another issue with these patients. So with these individuals, we give vasoactive medications for up to 5 days. It's going to decrease that portal vein pressure. We do endoscopic procedures like banding, and pretty much they put a band around that varices to stop the bleeding. The book did mention sclerotherapy. With that one, they inject the solution that shrinks those veins and stops the bleeding. They give them beta blockers. This is going to decrease that systemic blood pressure and reduce that variceal risk. The book does mention a Sinstaken Blakemore tube or balloon tamponade. You'll hear me call it Blakemore. This is considered like your emergency situation. They don't really use it a lot. I want to say I've seen one in my entire nursing career, but you have to be careful of the risk. It can migrate back up and cause airway destruction, airway obstruction, forgive me, as well as esophageal rupture and aspiration. This is your paracentesis, what it would look like. I've already talked about it, so I won't beat a dead horse. Keep in mind, they do take those samples and send them to the lab to make sure there's no growths or any type of infection in that fluid as well. This is that Blakemore tube I was telling you about, and it controls the variceal bleeding by compression. It goes through the nose into the GI tract, and it inflates the balloons in the esophagus as well as the stomach. Um, Again, we don't use it a lot. Is considered to be done for your emergency circumstances. With these patients, we don't want to keep this in for longer than 24 hours. And also, you want to keep scissors at the bedside in case it becomes dislodged or the patient's trying to pull it and got an airway obstruction. So you can just cut that tube to be able to give that patient the ability to breathe again. So when we talk about our surgical management, we're looking at the TIPS procedure as well as your liver transplantation. So with the TIPS procedure, it stands for transjugular intrahepatic portosystemic shunt. So basically the breakdown in that is going to, remember you got the portal vein hypertension due to the backup of the traffic with the blood. It also decreases ascites because you got a shunt that is created between the portal and the systemic veins. They say it's used pretty much in like your refractory fluid accumulation. Okay. The particular picture there is figure 59.7. Um, uh, So for your surgical management, you got a TIPS procedure and a liver transplant. This is figure 59.7. TIPS stands for transjugular intrahepatic portosystemic shunt. And what it is, you got a shunt that goes between the portal venous system and the systemic venous system. And what this does, it reduces the ascites as well as that it reduces the ascites accumulation, and that's going to decrease that pressure within that area. Your liver transplantations, for those, we are looking at, these are going to be most common for your hep C patients. And they can do your orthotopic transplant, that's from a cadaver. You also can do a living donor. They say they do a right lobe transplant. So again, you got to consider the post-op needs for this patient. This is going to be long-term management. They are going to have to be on lifelong immunosuppressants, because what happens is whenever they get that transplant, the body looks at the new liver as a foreign substance, and it will reject it or attack it. That is a complication of the liver transplant. They say it happens within 4 to 10 days, according to the book. So as the nurse, we have to look for signs like fever, right upper quadrant pain, tachycardia, bowel changes, even jaundice, of course. Sorry. You also got to look at, you have an increased infection risk, because with those immunosuppressants, it's easier for you to get sick. Uh, let's see, I think Cellcept is one of them, CELLCEPT. I forget the other name for it. But either way it goes, you got to make sure that you take those immunosuppressants religiously, and that's pretty much with any particular tissue transplant that a patient experiences. So as far as your complications, and I'm going to talk about these in a varied sense. So needless to say, we do have hyponatremia due to cirrhosis. Why? Because remember, you have displaced fluid, and that sodium is going to follow the out of the bloodstream into that third spacing area, because remember, salt follows water. You also have impaired renal water excretion as well. This is going to give you that greater water retention, more so than the sodium retention. You can also have spontaneous bacterial peritonitis, or SBP. This is going to be where your ascites fluid is infected. We see signs of infection with this patient: encephalopathy, hemodynamic instability, fever, abdominal pain. It's diagnosed via paracentesis, and they'll do cultures, and they'll say you're positive for whatever bacteria per se in your fluid culture. A lot of the times that includes, excuse me, I'm sorry. A lot of times that includes E. coli, streptococcus, Klebsiella. Your treatment for that is going to be antibiotics, and sometimes you have to do it like per se prophylaxis. Your hepatorenal syndrome, or HRS, this is going to be a rapid kidney function decline, because we have an alteration in that renal blood flow. It has a high mortality rate, and your main treatment for it is going to be liver transplant anyway. With these patients, I'm so sorry, y'all. These patients, we're looking at increased creatinine, increased BUN, of course, and then know that you also can have issues with the urine output either being decreased or normal. So we have another question here. Nurse is caring for a client with cirrhosis. Which of the following findings should the nurse identify are indications of hepatic encephalopathy? Select all that apply. And there are your answers. You got fetor hepaticus, or either asterixis. These are going to be your later signs. Keep in mind the anorexia, the ascites, the abdominal pain. Those are also noticed like in your normal stages. When you get the hepatic encephalopathy, like we have gone way further than we need to, in means of your liver failure stages. So one of your overviews for it as far as management, our goal, we want to prevent protein overload. We want to reduce that ammonia production, and also correct those fluid and electrolyte balances. Things that we need to do for this patient include small frequent meals. Be careful when it comes to those proteins. Remember, ammonia is the breakdown as far as the waste breakdown with protein. So when the protein breaks down, it creates new ammonia. The liver is no the liver, Lord, I'm sorry. The liver normally removes the ammonia from the body. Remember, the liver has issues at this point, so therefore ammonia is going to build up in the blood. Um, I want to say the book mentioned antibiotic for reducing GI bacteria as well as decreasing that ammonia, and that's neomycin. Lactulose, remember, we are titrating that lactulose for multiple soft bowel movements per day. The orders are written kind of funny, but it says like with in the hospital to say titrate lactulose doses for 2 to 3 bowel movements a day. But just know whenever they take that lactulose, it is going to make them poop. We look for diarrhea. We look for fluid shifts, electrolyte changes. I want to say the book even mentioned like supplemental vitamins like A, B complex, C, K, folic acid. And yet another question. A nurse is planning care for a client with fluid overload due to ascites. Which of the following interventions should the nurse include in the plan of care? Select all that apply. And I'm sorry if y'all hear noise in the background. That's my washing machine. And your answer is measure abdominal girth, weigh the patient daily, monitor intake and output, and check for your peripheral edema. So remember, when we're measuring for abdominal girth, you use whenever you take the tape measure to measure around. I want to say it's close to, it has to be like close to the umbilicus. However, um, if that's not the case, when you're measuring, just make sure that you're measuring in the same exact area. I think the book says something about marking it in that place, to make sure that you know it's not, when a different nurse comes behind you, the measurements won't be off. So your signs and symptoms with these patients, of course, is going to be related to their liver's inability to function normally. So think about the things that the liver is responsible for: metabolism, processing carbs, fats, proteins, detoxification. We're filtering toxins and drugs, bile production that's going to aid in fat digestion, storage of vitamins and minerals, synthesizing blood proteins and clotting factors, immune support, helping fight infections, as well as helping the body deal with issues with acid-base disorders, right? So at the end of the day, it's a lot of things that the liver is responsible for, and if you have liver issues, it's a lot of things that will be affected. All of your listed nursing diagnoses. So when it comes to our assessments of things that we need to be looking for, so if you're looking at the respiratory system, remember you have issues with fluid overload with these patients. So we're listening for like crackles in the lungs, decreased breath sounds. Um, we're looking at vital signs. You could have fluid excess as far as hypertension goes. If it drops, it could be because the patient has issues with low albumin. So the job of albumin in the body is to push that extracellular fluid back into the intracellular level because it's a protein as well. You can also have issues as far as with vascular fluid shifts. So sometimes when you have patients that are in the hospital and they have low blood pressures or they have a lot of fluid buildup, the doctor will order for the patient to have albumin to help push that extracellular fluid back into the cell. We assess for edema and girth. Remember, the more distended you are, this is indicative of a buildup of ascitic fluid as well as salt and water retention. The patient is easily bleeds because of the issues with the clotting factors. So you can look for things like gum bleeding, excess bruising, petechiae, nosebleeds. Jaundice, of course, the patient can be yellow. I want to say jaundice urine is dark, amber colored. They also say you have pale stool because of the bilirubin being elevated. We look at it, the hepatic encephalopathy as far as the mental status is. We assess that patient for any type of mental status changes. Remember, we look out also for the asterixis. That's going to be the excessive flapping of the hands and the wrists when the patient extends the arms in front of them. Okay. We track eyes and nose to get the daily weights because remember, you gain fluid quicker than you gain weight. We assess that acid-base imbalance. A lot of the times, this patient ends up with like respiratory or metabolic alkalosis because you got ammonia issues. The patient can have vomit and diarrhea issues, or even your diuretics. And also with this patient, you look out for the transplant rejection if they've gotten a kidney transplant. So you're looking at signs of right upper quadrant pain, fever, bowel changes, jaundice, and remember, it said within 4 to 10 days post-op. So when we talk about things that we do to assist this patient, of course, we administer those medications as ordered. The patient may have diuretics. We want to reduce that fluid overload and the edema. Remember, they have electrolyte imbalance, so we have to replenish potassium. Then whenever you're replenishing potassium in a patient's system, always look at potassium and magnesium as a couple. So a lot of times your doctors will tell you to give a dose of magnesium as well as a dose of potassium. Also, you got phosphate issues because you have because you're on diuretics. The patient could have poor intake, and remember, your patients that utilize excessive alcohol, a lot of the times they come in needing vitamin replenishment because all they want to do is drink. They don't really care about eating. You got your sodium and fluid restriction issues that you want to make sure you look at. Remember the fluid accumulation, protein restriction. Remember I told you the ammonia levels rise. That's what causes the encephalopathy. Positioning, they get bad dependent edema. You want to elevate the head of the bed to help them with breathing. Elevate the legs because we want to reduce that edema, that dependent edema. Clotting support. Sometimes you may have to administer vitamin K, blood products, or plasma to correct the coagulopathy. Coagulopathy. I think I said it right. Those issues, the issues with clotting. And of course, also your energy conservation, encourage rest for these patients. And you want to, they say do like your hygiene, like seated. So you want to reduce strain on the liver. So when we educate for these patients, we educate about the diet. We want them to limit their protein and sodium, um, as well as the fluids, because we're trying to manage those symptoms and prevent progression of the cirrhosis. We got lifestyle changes being one of the main things we need to educate about. Avoid alcohol. Maybe you need to do like Alcoholics Anonymous. Avoid your hepatotoxic medications. That would be your acetaminophen, some herbs and supplements. Routine care. We're looking at labs and disease status regularly, right? Your nutrition. You got to eat enough calories with a balanced meal to prevent that malnutrition. And also, this patient is on bleeding precautions as well. So we want to use soft toothbrushes, gentle flossing, and electric razors. Remember, these are the ones that when they cut themselves, they bleed like stuck pigs. Um, this is the last slide of this presentation. If you have any questions, comments, or concerns, feel free to reach out to me. I'll talk with you during the next class session. Have a good day.